I'm Ben C.,
I'm Dr. V,
the medical,
the medical
legal,
legal
guys.
guys. Spring training edition. So what have we been doing, Ben Martin, over the past couple weeks? What kind of comes to mind?
Well, we've been handling up on COLOPLAST.
We filed the case in Baltimore.
Yep.
And we're about to amend a complaint against
and
COLOPLAST. And again, catastrophic pain syndrome,
pudendal neuralgia.
stiffest mesh, worse outcomes with safer alternative designs.
This is a mid-urethral sling. So what's a mid-urethral sling?
Well, mid-urethral sling is used for women after they have childbirth. They can develop stress urinary incontinence as they get older.
And it doesn't just have to do with childbirth. People, male and female, can have a stress urinary incontinence, which means they leak. Okay. The case of many women, it comes forth after childbirth, age, gravity. And so the mid-urethral sling's here to supposedly help those issues. And the mid-urethral sling is made of polypropylene, if it's a COLOPLAST sling, and that's a plastic. And tell us a little bit about the Eris device.
The Eris is their transobturator sling. It's a sling that supports the mid-urethra. And you have a vaginal component and arm component that goes in the leg.
Used to lift up the urethra, which is the tube that goes from the bladder and out the body to expel urine. Is that right?
Yeah. Polypropylene, the days of polypropylene are kind of on their way out because
polypropylene is on the ropes.
Basically, and it's because they're safer materials that don't include the plastic weave of mesh that causes inflammation and pain and erosions. And they have other materials that don't have that, as they have less inflammation, they have less erosions, and the degree of inflammation is markedly less. And that other type of mesh is called PVDF, and it doesn't shrink. Polypropylene shrinks, and if you have muscles under tension and nerves under tension, you could have muscle and nerve pain. And unfortunately, those are the women that we represent. And we believe that this device, the outcomes show that it's the worst device, and the warnings do not fully capture the frequency of risk and the severity of risk. And I don't think any doctor would choose polypropylene over PVDF.
And Dr. V, a doctor who knows, who is told the truth about this product, we say wouldn't put in the product, or at least is going to tell the patient about the product. And once the patient is told the truth about the product, then the patient has the decision to make, and patients, if told the truth, will make the decision not to have the sling.
So the big problem with this in terms of pain, it causes 2.8 times the amount of frequency of dyspareunia. And that's kind of goes to the heart of the safety of the device because it's placed vaginally. But it also causes some extreme pain syndromes because it inserts on the obturator internus muscle, which is very close to various nerves. And that could cause muscle spasm, dystonia, pulling on nerves, and some serious pain syndromes. And PVDF, it's gaining market share in Europe. This PVDF has been tested 1-to-1 against polypropylene transobturator slings and was superior in terms of pain and erosions, and it's a better material. And so we're suing the manufacturer for failure to warn doctors of the specific increased risk of pain and dyspareunia, the severity of risk, but also that this is a design defect because there are safer materials that need to get to the market. And the Eris sling and the Altus device, they seem to be the worst.
All right. So there's your COLOPLAST. We could go on for hours and for days, but that's a general update on what these cases are about.
So we also filed a case that's very important in Wisconsin, okay? And it involves time is brain.
Okay.
And so it's a serious injury case.
The time is brain doesn't have anything to do with the COLOPLAST, doesn't have anything to do with the mid-urethral sling. So let's talk about a new case we filed in Wisconsin, and other cases exist that are similar to this case.
Time is brain is now the standard of care when a person presents to a hospital with symptoms or signs of a stroke. And there are certain tests that need to be done within a certain time frame, and interventions must be provided or offered because the outcomes are superior when a person comes with an ischemic stroke from a blood clot in the brain.
Right. Ischemic stroke
Yes.
and hemorrhagic strokes, two types of strokes. And Dr. V just explained hemorrhagic.
Hemorrhagic, very nice.
And there's also the ischemic brain that involves a loss of oxygen because of a lack of blood flow or a lack of oxygen. That's an ischemic stroke. And a hemorrhagic stroke, which Dr. V is talking about in Time is Brain, is the type where you actually have a bleed, a vessel bleed in the brain, and that's a bad thing.
That's a bad thing. And obviously, you want to get proper care, proper blood pressure management. Earlier treatment, the better, obviously, in terms of preventing complications. But clearly, with ischemic strokes, you're on the clock, okay, to get this done. And our client, unfortunately, presented to the hospital, had symptoms and signs, we allege, of a stroke. And then they didn't run the diagnostic test despite a code stroke, that a nurse had significant concerns that a person was having a stroke, and they didn't follow through on the policies and procedures, we allege, in terms of the standard of care for the next test, which is to give a CT angiogram to see if there is a clot that can be either extracted with via thrombectomy, a catheter that can grab that clot so that the blood flow can return, and or the thrombolytics or blood clot busters by veins. So it's really a sad situation. And then, unfortunately, this gentleman then developed 2 very big grade 4 bed sores.
Right.
It's a nightmare hospitalization, and could have been saved. He had other medical problems that would have been taken care of.
So time is brain. And that's what this is all about. The faster you get to the patient, the faster you understand what's going on with the patient, the faster you diagnose the possible problems, and then the faster you get to the problem. It's very important, because the faster you get, the better opportunity there will be to save that patient's health.
And this occurred in the hospital within 12 hours, the change in neurological status. So it's kind of a bad story.
It is a bad story. What I want to talk about with Dr. V today is just kind of some of the general aspects of time as brain, and general aspects of what kind of diagnoses are made, what kind of indicators are there, what kind of diagnostic tests are there to make a determination as to whether or not somebody coming in with symptoms that are consistent with a stroke actually may be undergoing a stroke, and why time as brain is so important.
You know, these are serious. When you have a large vessel blood clot, that's like a hose that goes to various other parts of the brain. Okay, so it gets the hose and you lose a lot of brain, and the prognosis is significant. And to miss a large vessel stroke is very bad. And also a small vessel stroke, there is benefit from thrombolytics, better outcomes.
You got to do them.
Yeah,
you got to do the diagnostics to see what kind of thing is going on, what kind of things are going on with the patient. That's called, Dr. V, we've talked about this before, that's called making a differential diagnosis. You see in medical records a lot, R/O. That means rule out this particular condition, this other condition, this other particular condition.
Yeah, but a code stroke, you know, a nurse is ringing the bell, an ambulance driver is ringing the bell that they have a code stroke, and everyone in that hospital knows what should be done and what is next. Okay, it's a highly predicted diagnostic plan with certain minutes and hours and windows where it shows outcomes are different. So there should have been nurses to say, hey, what about this? Okay. I mean, you have to think critically and understand, hey, this is what normally happens. Why not this case? You know, and ring the bell again.
That code we're talking about. So that's important, because once a code is called, then it's being called because this patient is suffering from something that is likely to be a stroke or something else very serious. You don't call a code if somebody's not having a serious problem. Is that right?
Yeah. There's coordination of care. There's expectations, that the point that they then didn't identify or that there was a problem with the code stroke for 2 days.
Big problem. These things that happen in hospitals and these things that happen with physicians, and everybody understands that hospitals, nurses, and doctors under a lot of pressure. Let's kind of talk generally about what hospitals do and the circumstances. And I'll tell you this, that hospitals now, because of all the science that are supportive of a particular protocol, hospitals have protocols and societies put out protocols of what are you to do in a situation where somebody's presenting with a stroke or stroke symptoms or symptoms that could be a stroke. And I'll tell you one thing that's coming into play is artificial intelligence is out there. There are apps that physicians have and nurses have access to that will tell the nurse, the physician, your situation, what to do about this stroke-like condition, this medical condition that appears to be something that could be loss of oxygen leads to death of tissue. So it's important not just with respect to the brain and strokes, but with the other things.
Like preventable injuries. So those algorithms that goes to the fundamental aspect of nursing to prevent it. Okay.
Also to prevent death from strokes.
Correct. And stroke is a priority for hospitals, acute care hospitals. That's why they're different. They're supposed to be a safe place that, hey, a person comes in with a code stroke, symptoms of a stroke, that it deserves a CT scan and then a CT angiogram. Okay. It's just failure. And then hospitals are not following general protocols on how to keep people safe and to prevent these types of complications in hospitals. I practice hospital medicine. It takes ongoing education. It takes ongoing assessment of the stroke alert protocol. And it's just an ongoing management. People are injured and we get the policies and procedures, which are the internal documents of how a hospital runs. And we understand what they're supposed to do. So maybe we should go away from time is brain and get an update on Depo-Provera.
We represent women who have received the birth control injection called Depo-Provera, also known by its chemical name.
It's medroxyprogesterone.
Oh.
I want to update on what I've been doing with Depo-Provera.
Sure.
I went to Kalamazoo, Michigan with some busy lawyers and we looked through hundreds of boxes. Hundreds of boxes of internal documents.
650 documents. 650 boxes. Of
like
documents.
boxes. Original sources of the Beagle study.
You ran into those? That study?
Yeah, beagle monkeys.
I haven't even heard about this.
Yeah, so beagle monkeys and all the original documents, which is important because we kind of understand the history and we understand where these documents can be found. But some of these documents are like 40 years old. I don't know how to get a 40-year-old document, but it's in a shed. It's in a big warehouse up in Kalamazoo.
Now, let me tell you, we'd love to talk to you about the specific internal documents and some of the things that we found, but we can't because we are under what's called a protective order. And so we have to be circumspect about that. And so though we can't tell you about what we found, we can certainly tell you about the process. And I've never been to Kalamazoo, but have you been to Kalamazoo?
Never been to Kalamazoo, but
you like
hands down, the best Thai restaurant I've ever had in my life.
Really? Give them a plug. Yeah. What's the name of it?
Bangkok. It's been there 25 years, back-to-back days, dinner, then lunch, and then I had to catch a plane. I would have kept on eating. It was amazing.
This is really important. He always wants to go to Thai food, always wants to eat Thai food.
It's very tasty.
So if you're in Kalamazoo and you like Thai food, or even if you don't, you might like this Thai food.
Yeah, so, but we represent people in Michigan. I might be back to Kalamazoo, especially, for a Depo-Provera case or catastrophic pressure injury or other types of serious injuries.
So what you do and why we go to places that have these document reviews prepared for us is in discovery, these things are requested. And then ultimately it's determined what is able to be looked at, able to be reviewed in the investigation of a medical device case, a pharmaceutical product like Depo-Provera, or even a non-medical product. These are called document reviews, and we learn things from the internal documents of company. Can't talk about the specifics, but it's part of the process of an investigation as to whether or not a particular product causes a particular disease or medical condition. That's called general causation, okay? And then you take that not just from the internal documents, but from all of the scientific literature, and you make a determination as to whether or not the literature supported by other documents concludes that there is a greater risk of the development of a condition, in this case with Depo-Provera, a meningioma, a brain tumor, particular type of brain tumor.
Documents. Okay, so obviously,
Don't talk about the specifics, but
yeah,
old
they're
documents.
really old. They're quite old documents, and obviously the newer documents are important in review and understand what the company knew as it relates to meningiomas. And the literature does point to it in 2006.
Yeah.
So obviously there is literature that pregnancy meningiomas grow during pregnancy, and that's been known since 1920 or so. Progesterone is made by the placenta. And so it's during pregnancy, meningiomas can cause symptomatic meningiomas, but then it shrinks. So it's interesting. I'm looking forward to reviewing those internal documents.
So putting together a case like this, you need to prove that this condition, meningioma, truly can be caused. And then what's the relative risk of this? In other words, how strong is the association of a medical device, a medical product, a pharmaceutical like Depo-Provera? How much of an association? Is it an overwhelming association? And in this particular case, these particular cases, Depo-Provera, it has been found that there is a relative risk of in upwards of 5.7, almost 6 times the relative risk, 600% more probability of development of meningioma with Depo-Provera use for at least a year than not. So that's pretty big.
I just don't get it anymore that there's safer medications that achieve the same result. Oral birth control, Mirena for a medication impregnated intrauterine device. It's an IUD that has progestin that helps prevent conception.
I'll say this: Depo-Provera, medroxyprogestin, right? It's a synthetic progestin.
It's a synthetic progestin, and progesterone is a natural progestin.
Right. So this synthetic product that is put into the body, it's injected, and it is effective. It will prevent pregnancy. But they use a lot of it. They probably shouldn't use as much as they do as far as the dosage. But the dosage is prescribed. What comes in the package insert tells you how much to put in and how much of a dose there is. And then that's what the physician's assistants, the ones who are injecting the medication, that's what they're told to do, and they do it.
I'm just saying meningioma is a serious medical problem. It's a serious medical problem. It's not like a rash that you stop the medication and 5 to 7 days. Even a severe allergic reaction to skin usually gets better in 7 days. When you're talking about a meningioma, that's a serious medical condition that would freak out anybody if they are heading towards surgery. So,
well, nobody wants a meningioma. Nobody wants a brain tumor. Meningioma is the type of brain tumor that most exists out of all the other brain tumors. But you see it more often in women who take or are injected with Depo-Provera as opposed to women who are not injected with Depo-Provera. And that's the problem.
Yeah, and also have a bit of a tendency to be at the skull base and tend to be multiple. Both are bad things. The skull base is harder to take out a tumor going this way at it as opposed to this way. It's at the skull base. It's trickier surgery.
Yeah.
So it's kind of a brutal scene.
Women who do have meningioma and were injected with Depo-Provera, that is evidence that they have suffered from that drug and suffered meningioma. And that actually is called specific causation. Remember when we were talking about general causation? Specific causation, did the substance cause the condition in this particular person? In other words, that Depo-Provera that they took, that were injected with, caused their meningioma at a relative risk of 600%.
So we're busy with Depo-Provera. We're filing cases. And we're looking at the national litigation. Obviously, represent people in almost every state. Every state?
Yeah. We were talking the other day about
Alaska,
and Hawaii. Yeah.
Alaska.
So
Hawaii.
not only the continental United States, but the United States.
Another case we filed was a time is spine case. Yeah.
So, well, you're the doctor. Explain what time is spine.
Time is spine. If you have symptoms of a spinal cord injury by way of infection or fracture, dislocation, if you have symptoms that would suggest a neurological issue involving the spinal cord, you need to get imaged. And if there is an infection causing pressure on the cord or bony compression or an acute herniated disc, you got to get that patient to surgery sooner the better, but within 24 hours. And the outcomes are different for people who get surgery within 24 hours versus those who don't. So we have a quadriplegic male that we represent in Los Angeles who time of spine. A MRI was done towards the end of the first 24 hours. And we allege that the findings on that MRI show us a problem that would result in his loss of function and his pain. And ultimately, they repeated the MRI 4 days later and then transferred him out for surgery. So you understand that there was a delay in terms of time of spine. And, this gentleman, we allege, could have been saved.
So a tragic case. Let's talk about time of spine in a more general way too. So we talk about what that means and what it is with respect to just cases generally.
Yeah. So if I could explain that, normally, if you have symptoms of a spinal cord problem that's leading to pain with loss of function or severe intractable pain, or symptoms of fever with severe pain, progressive neurologic loss, that requires a emergent MRI. And with early diagnosis, if there is a problem related to compression of the spinal cord, you need to decompress that spinal cord. It might be infection, an abscess. It could be an acute herniated disc. It could actually even be tumor edema. But if you diagnose it, you can then provide decompression of the spinal cord, which will improve function and prevent neurological loss. So, people go to the hospital walking and then are discharged in a wheelchair with or without incontinence of bladder. Those cases, we review those types of cases. I'm a doctor and I practice hospital medicine. I'm a spinal cord injury doctor. I'm a brain injury doctor. I've seen all the stories of complications because the bad complications would make it onto my rehab hospital. I'm seeing all the bad outcomes. So I know all the scenarios when I'm reviewing records or talking to a prospective client to understand, is there something that we need to order medical records? So I kind of provide that first conversation.
It's good to have a doctor on board that can really sort of be the first investigator. A lawsuit involves an investigation. Investigating every lawsuit, doesn't matter what is involved. And the first investigation is in a case involving, let's say,
a bad outcome.
A bad outcome.
Yeah.
What caused that bad outcome?
Looking for breach of the standard of care, liability, and did that cause injury? So same thing. You're going in for labor and you then have a child with hypoxic ischemic encephalopathy. There's questions. It always comes to the fetal strips, and my law firm, we have an OBGYN on staff. We're getting the history. We're discussing with an OB expert and trying to understand things very quickly so that we can then act with direction to get the specific medical records and what we need to prove up this case, okay? Because families need to understand this as soon as possible. This is on their mind and they need to understand.
You want to talk about bed sores?
Bed sores. So
we have a couple of recent cases that have come in, and very interesting cases. If you ever hear a lawyer or a doctor talk about an interesting case, it's not to minimize the tragic nature of a case or the seriousness of a case. An interesting case has interesting facts that ultimately lead to tragedies, right? But we look at those cases as having interest or being interesting, but they can be so tragic. And one of the biggest tragedies, I think, out there now, because of how often it seems to be occurring and the serious nature of what brings it on and what brings the condition on, are the bed sores, also known as decubitus ulcers, also known as pressure sores or pressure wounds that occur in hospitals and nursing homes and long-term care facilities where a patient is not being turned properly and pressure exists on the limb, and pressure then goes into the muscular part and the tissue of the body and causes these horrible wounds. You have a situation with failure to turn. That's generally what the problem is.
Failure to provide reliable pressure relief to a dependent person being one who, when in bed, can't reposition themselves because of illness or injury. Or if they're up in a wheelchair, they're put into a wheelchair, but they can't scooch their butt up to do a pressure relief and take pressure off where you sit. So it's really neglect at a really tragic level. What we're interested in is, some of this nursing home and these companies that are ultimately owned by Wall Street in terms of understanding.
So nowadays, you have these hospitals that are being bought up by hedge funds, and as Greg says, Wall Street, right? And a lot of times they'll buy up the real estate and they'll run the hospital, right?
Or the nursing home, that they buy the nursing home and the real estate, but then they sell the real estate to a REIT, and the REIT is charging them
real estate
rent.
Investment trust.
Yes, so they're paying this entity that's owned by them rent, and then they're charging the entity for management. So if you have too much going that way and too much going that way, you don't have enough money to educate your staff on how to prevent these types of injuries. Ongoing education is paramount. You aren't potentially hiring the staff to manage the population, because the population, there might be too many patients for the staff, or the patients may be too sick for the level of staff provided. So we want to understand those standards of care and how that is communicated to the entities that own the nursing home. These entities are taking the profit and not reinvesting to prevent. I think those are important issues.
And maybe that's why we're seeing so many of them, because a bed sore is a never event, according to Medicare. It should never happen.
Never.
So there you go. We've had a good couple of weeks of work since we last were here. Hope we have another couple of good weeks, hopefully helping some people. And we will see you guys next time on Ben C. Dr. V and the Medical Legal Guys.